For him to go into it and no one know it, it could have been a disaster.
Feeling jittery and nervous for no good reason, Daryle says he knew something was physically wrong. While his diagnosis was common, the solution would be a first. Good morning, I'm Alexis Del Cid. Welcome back to All Things Heart. Life was going great for the man you're about to meet. Then one day, out of the blue, he was hit with a racing heart. Luckily, he had an ace up his sleeve, his high school sweetheart and her connection to a new procedure to fix it.
Here's our little stand of persimmons.
Married for 41 years, Daryle and Susan still love each other's company.
We went to high school together. Then right after high school, we started dating.
And they still laugh when talking about the moment they met in high school.
I'd gotten my eye injured and I had a big patch on it. He said that's how he remembers, is that he seen me walk down the hallway and I had that patch on my eye. And great memory.
With her bubbly personality and that quirky patch on her eye, Daryle fell for her. Hook, line, and sinker. Now the couple spends as much time as possible at their cabin in Eagle Rock, Missouri, trout fishing.
This is our getaway.
It's peaceful.
Peaceful. And we're down here 2 or 3 times a month.
The big one right there. Oh, I got him.
That's a nice one.
There's nothing you worry about when you're standing in that river. There's fog on the river. You see the eagles flying over. It's just the best feeling in the world.
2 to 1.
I won.
But their carefree life together became incredibly stressful on a Sunday afternoon in July of 2023, when out of nowhere, Daryle says his heart started racing.
I came in the house and I told her, I got something going on here.
Susan, who also happens to be a certified medical assistant, took his blood pressure, and then she took him straight to the emergency department. Daryle was in Afib, atrial fibrillation, when the heart's upper chambers beat out of sync with the lower chambers. Left untreated, it can be deadly. But after a few days in the hospital, Daryle says the Afib went away.
I had no symptoms. I felt fine.
Doctors sent him home. A year later, Daryle still felt fine, but it was time for his checkup. Susan encouraged him to see the cardiologist that she happens to work with at the University of Kansas Health System's Olathe campus, electrophysiologist Dr. Ravi Yarlagadda.
One of the girls go in and get him put in a room, do an EKG, and she walks out and walks past me and holds up the EKG and she goes, "He's an Afib." You could have knocked me over.
It absolutely shocked me. I had no idea.
Dr. Yarlagadda told Daryle that he was the perfect candidate for a procedure called pulsed field ablation.
It's the new kind of ablations.
Not only that, but Daryle would be the first patient ever at the Olathe campus to undergo the procedure. For Daryle, saying yes was a no-brainer.
He's a good man, has a lot of confidence and kept me that way. Knowing everything was all right, very reassuring.
It was also a first for Susan. Instead of being in the procedure room working, she would be in the waiting room. Please welcome Daryle and his wife Susan to today's program. Thank you both for being here.
Thank you.
We also have Daryle's electrophysiologist, Dr. Ravi Yarlagadda. Dr. Yarlagadda performed Daryle's pulsed field ablation, and he is also the chief of medicine at the health system's Olathe campus. We are so grateful that you've carved out a little time to help us talk to our viewers about everything you've done for Daryle and that you continue to do for your patients. Daryle, first off, how are you feeling today?
I feel good.
Feel tip-top?
Yeah, everything is good.
I have to ask Susan. I know I asked you if you had any pictures with Susan's eye patch on from high school. Do you have any? That's just the cutest story. I just love the story of how you guys got together and how you met. Pulsed field ablation, when it comes to the medicine, is relatively new. You were the first one to undergo the procedure at our Olathe campus. What were your emotions like knowing that and going in for the procedure?
Well, I had never been in the hospital other than the emergency room, so that was something new, but I trusted Dr. Yarlagadda, and it was really easy.
You just had this confidence that, based on his confidence,
Yeah.
which is a great bedside manner and a great thing to exude to your patients. You gave them a feeling that it was going to be okay.
That is correct. Yeah.
Susan, you also have a special tie to both the men sitting here. Not only are you married to Daryle, but you work with Dr. Yarlagadda. So how did you feel about those two worlds colliding?
Great. I never even, I didn't even think about it. It was just a no-brainer. Just get it done, fix it.
How weird was it to not be able to be in the procedure room and to be the person in the waiting room?
I guess it didn't bother me. I mean, I knew he would take care of it, and he would come out and tell me when it was done. And
did you want to go in there? No, having seen procedures.
Oh yeah, I would have liked to have been in there.
That is something I'm not sure was a good idea. But
Right. No. Your friends might have been like, Susan, back up, we're working here. Right.
Yeah, no, wouldn't be a good idea.
Dr. Yarlagadda, before we get to the pulsed field ablation and how it works, I want to ask you about Afib so we can help our viewers better understand what's happening. And we have an animation that we want to play while you explain to us what's happening inside the heart that causes it to beat out of sync. What is the trigger when someone goes into Afib?
So the human heart has two pacemakers. These are the biological pacemakers that all of us are born with. And they're present in the right upper chamber of the heart. So in patients with atrial fibrillation, you have these electrical connections in the left upper chamber of the heart, usually around 4 blood vessels called the pulmonary veins that is shown in that picture right there. And it is these 4 blood vessels which should not be having any electrical impulses coming out of them cause atrial fibrillation. So there are multiple causes for that. The most common cause is usually hypertension, sleep apnea that is untreated, and family history of atrial fibrillation. Usually those are the major culprits for atrial fibrillation. So the intent of atrial fibrillation procedures is to figure out where these impulses are coming from and then treat them accordingly. In more than 90% of the patients, those impulses are actually coming from the left upper chamber of the heart, around those 4 blood vessels that is depicted there.
So Daryle, did you have any of the 3 contributing factors that Dr. Yarlagadda mentioned? It was sleep apnea, high blood pressure, or a family history?
Just high blood pressure.
And do you think that was the trigger?
That was probably the trigger for him, yeah.
Do people ever randomly get AFib, or is there always one of those 3 triggers?
Actually, that is, I've seen many patients where actually they don't have any of the traditional risk factors that you normally see in atrial fibrillation. The classic examples are runners, right? Especially long distance runners have high risk of atrial fibrillation as well. So it is not necessary that you need to have the traditional risk factors. Sometimes it really is de novo and completely comes out of the blue.
That's interesting. Yeah. So in Daryle's case, his first bout of AFib, that went away, and you thought you were in the clear.
Yeah.
Then it came back.
Right.
Is it possible for AFib to ever go away without a procedure and stay away, or was this destined to come back for Daryle?
So in most, again, in medicine, it's hard to say that anything is 100%, but in most of the cases, when you have atrial fibrillation, you have a trigger for that, and it almost always comes back in the correct setting. Usually, the first time the patients have AFib, it usually spontaneously resolves and does not show up for about a year or 2, and then it comes back again. Now it lasts for longer periods of time, and then it goes away. So as all of us get older, it happens more frequently, it happens for longer periods of time. So the progression of the diseases, it goes from being in paroxysmal, as the name implies, it comes and goes, to being in persistent, where it stays in AFib all the time.
Paroxysmal means it comes and goes?
Comes and goes.
Okay.
And then it transitions into persistent, where your heart is just in atrial fibrillation all the time. So the key time to treat patients with atrial fibrillation is when they're still paroxysmal, meaning when they are in and out of atrial fibrillation by themselves.
When it comes to the treatment, pulsed field ablation, we have some video of you performing that same procedure, pulsed field ablation, on someone other than Daryle. It's you and your whole team. What are you doing during a procedure with pulsed field ablation?
So the first is getting access to the heart. So we put a catheter through the right groin. We actually go up into the right upper chamber of the heart. Then we get access to the left upper chamber. So what you're seeing right there is mapping of the electrical system of the heart. As you can imagine, atrial fibrillation is an electrical problem, so you really cannot see electricity, but you can actually map it. So that's what those colorful pictures are about, is mapping the electrical system of the heart and seeing where these abnormal electrical connections reside. So that's called mapping and tagging those signals. Then we put up a special catheter and then eliminate those signals. So the way we eliminate them in the past has been with thermal energy, be it heat energy, which is radio frequency energy that we have been using it for almost 20 years. We could use cryo energy, which is freezing technology that has come out probably 10 years ago. And the latest is pulse field ablation, which is non-thermal energy, where it is definitely much more safer than any of the prior energy sources that we have used. And the success rate, the acute success rate is extremely high.
We have some images that you've shared with us. They're really cool, and I'd love for you to walk us through these images. We have some before and after of Daryle's heart after his pulsed field ablation. Daryle, is this the first time you're seeing these?
I think so.
What do you, cool, right?
Yeah.
It looks like some abstract painting that you're hanging in a museum or on a
Quite
wall.
colorful, right?
Yeah.
There.
Dr. Yarlagadda, what are we looking at in the left image?
So that is Daryle's left upper chamber, which is the left atrium. So
And that's before?
That's before the ablation, and the camera is actually looking at the back of the left upper chamber of the heart. So what you're looking at is the back side of the left atrium, and as you can see, there are 4 blood vessels that get into the left upper chamber of the heart.
Like those 4 arms
that
sticking
are
out.
actually coming
Okay.
out like that. So those 4 blood vessels should not have the color purple in them. Purple denotes electrical activity. So the blood vessels really should not have any electrical activity in them. So as you can see, all those 4 blood vessels in Daryle's case were electrically active, and thus they have the color purple in them. So once you eliminate that electrical activity, which is the picture onto the right side of the screen, you really don't see any color purple, and it's all red. And the color purple that you actually see is now just in the left atrium, which is the heart muscle itself, like the way it should be. So that's the difference between the pre and post ablation pictures of Daryle's left upper chamber.
And is this newer, the pulse field ablation, the only way you treat Afib now, or do you ever go back to those 2 older methods?
So it has been so effective that it's really a quantum leap for us.
Wow, quantum leap.
A quantum leap for us. It is, the safety of this is something that we have not seen before. The efficacy of it also is quite something else. So I really doubt if we'll ever go back to doing this particular type of ablation without using the pulse field ablation.
Daryle, you were a trailblazer. You were like a pioneer, the first at our Olathe campus undergoing this. We also have some really, you thought those images were colorful. You shared 2 more with us.
Right.
Check this out. Okay, these are images of another patient of Dr. Yarlagadda's, not Daryle. On the left, whoa, that's a patient who actually had been treated previously for Afib with one of the older methods.
Right.
And it came back?
That's correct.
What are we seeing there with those splashes of all those colors?
This is a patient with persistent atrial fibrillation. Remember, I talked to you about patients with paroxysmal atrial fibrillation, and as they progress along, they convert to being in Afib all the time. So this is a patient who had an ablation by us probably in the like 10 or 15 years ago.
And what kind of ablation?
That was radio frequency ablation, which was the heat energy, which was the only type of energy source that was available to us at that point. And you know, he was quiet for about 5-6 years, and he came back with atrial fibrillation. So here you can see the entire, again, this is the left upper chamber of the heart, and you can see the back side of the left upper chamber, which is really in a mosaic pattern. So you really, it is really dense scar tissue and electrical activity that should not be there. So that was the picture that this patient had prior to the ablation, and the photo next to it is the left atrial chamber of the heart after an ablation, once we did it with the PFA. So now you see the newer technology. So now, as you can see, all the blood vessels, the 4 arms as you talked about, have remained red like the way they should be. And the posterior part of the left upper chamber of the heart is completely, does not have any electrical activity. So this is, so in a patient who has persistent atrial fibrillation, who had prior ablations done before, we target the back side of the left upper chamber and basically eliminate all electrical signals. The difference between this particular procedure and the prior ablations is the backside of the left upper chamber is very close to your esophagus, which is your food pipe.
Yeah.
So as you're cauterizing the backside of the heart with heat energy, there's a very good chance that you're going to hit the esophagus, or there's a nerve called the phrenic nerve there, so that there's a risk of collateral damage when you use radiofrequency ablation in those patients, which was why we were very hesitant to do these extensive ablations in the past. Now with pulse field ablation, because it is so specific to the atrial musculature, the risk of collateral damage is essentially eliminated. So that's the reason why it makes it such a safe procedure to do.
And Daryle and Susan smiling, nodding your heads, yes. It must be a relief to be out of the woods.
Right.
Exactly.
Just feeling good, sitting here in a television studio next to your doctor. That's pretty cool. We have some great questions that are already coming in from our viewers. If you're watching right now and you have a question or a comment that you'd like us to read, send it to us on YouTube, Facebook, and the All Things Heart email. There is all 3 links on your screen right now on how you can connect with us in real time. So, Dr. Yarlagadda, I want to talk to you about the Olathe campus because it is so important, you feel, to be able to offer this procedure to multiple health system locations in the area. You're passionate about that.
Very much so. So the way our hospital is located is on the southern end of Johnson County. So we have a lot of patients who actually come from south of us. So most of our patients are rural. You know, they come from Miami County, Franklin, Douglas County. So these are really Kansans, right? They're true Kansans. So our ability for us to do these complex procedures in a location where they don't have to come all the way up here, where you're taking the medicine to the patients as opposed to the other way around.
Which is the
fantastic.
mission
Which is the
of the health
right.
system, is to
Right.
bring all these great advancements
Right.
to multiple locations.
Right. So I think we are very, very proud of what the work we do down there.
And Susan, you've also been treated for Afib.
Yes.
You know firsthand, and
Yes.
you work in a doctor's office with the head guy who treats this. Here's what Susan had to say about Afib.
Afib is a monster because I would say 50% of the people never know they have it. And I work around it a lot, and it's amazing to me when I hear that they don't feel it. I felt it. I was, a mess when I had it. He never felt it.
That is the scariest part, I think, of this story, is that, Daryle, you never felt it.
No, not after the first time.
Unbelievable. So, Dr. Yarlagadda, Daryle saw you. He was in Afib, but he just happened to be there for a checkup and had no idea. Is that typical, that a patient will be actively in Afib and not know it?
So when you look at the symptoms associated with Afib, some patients can tell me the exact minute they're in Afib because they feel so bad in it. They have palpitations, they have chest pain, they don't feel well, and they feel relieved once the episode is completed. In other patients, they are what I call minimally symptomatic. They really don't have the awareness of palpitations, but they actually are more tired.
Were you more tired? Nothing.
No.
They're actually more tired or more short of breath, or they have some symptoms associated with it. And usually, especially in patients who are in persistent atrial fibrillation, where they've been AFib for a long time, once you correct the problem, then they say, oh my God, I feel much better now. I just did not know how tired I was before as opposed to now, where I have more energy to do. So I think in patients who are physically active, I think the sense of well-being is actually restored once you're in normal rhythm, because they just really, it's atrial fibrillation is not a life-threatening arrhythmia. It'll never cause cardiac arrest or a heart attack, but if left untreated, it takes a toll on the heart. It basically gradually decreases the heart function. There's increased risk of stroke as well. So
which can be fatal.
Which can be fatal, but it's not as if you go into AFib and you're going to drop dead. So that does not happen.
Thank goodness.
Yeah. So I really think so. I think it slowly creeps up on you, the symptoms of atrial fibrillation, and the most common comment I get is, I just did not know how bad I felt until I actually felt better.
Was that your comment when you came out of it? I feel so much better.
Not really. I didn't feel bad.
See, that's the freaky
that's the
part.
scary
That's what
part.
makes a lot of people watching. That makes you nervous hearing that.
Yeah, it does. 'Cause
So how did you, between the time that you were told, okay, you're an AFib, we're going to do this procedure, there was a little bit of time. How did you continue to monitor your heart if you didn't have symptoms in the first place? At home, were you constantly checking your pulse or having your wife listen to your heart?
He recommended I get an Apple Watch, and it'll do an EKG. So,
Okay.
and I do one twice a day now, and I'm good.
Who would have thought 50 years ago that you'd be recommending watches?
I know.
To monitor their
Yes,
hearts.
that
And
is correct.
These smart devices are lifesavers.
Right.
Yeah.
Especially, there are two types of smart watches, right? One where you just get a heart rate on it. So an Apple Watches and some of the Galaxy, Samsung watches, you actually get an EKG on them. So the wearable monitors are certainly helpful in diagnosing arrhythmias. It could be a double-edged sword because some patients tend to get fixated on them as well. But,
Right, I would get fixated. I've been toying with wanting one, and I feel like all I would obsess about would be sleep. How many hours did I get?
Yeah.
it'll tell you.
They are such beneficial things
yes,
to have.
I would agree with that. Yeah.
We have some great questions already coming in. Stuart has a question. Stuart wants to know, he writes, PFA uses electricity for ablation. Previously, you used thermal energy from radio waves. Could you use ultrasound to ablate the heart?
So yes, there is actually a catheter that's actually in clinical trials where you can use ultrasound energy to do that. The answer is yes.
It's in clinical trials
That
right
is
now,
correct,
though.
yeah.
Jeremy has a question. He wants to know, is PFA something that could help with arrhythmias in general, or was it specifically Daryle's type of AFib that made this such a good idea for a solution?
So the PFA is an energy source, right? It's not a catheter. It's basically an energy source. So the catheter that is currently available is geared toward treating atrial fibrillation only. So down the road, we can have other catheters which still deliver the same energy, where we can use in the treatment of other arrhythmias as well, but they're yet to be available on the market.
Joe Ellen McGranahan wants to know, Daryle, what do you do for follow-ups? Are you on blood thinners? Do you have to get the Watchman procedure? What are your follow-ups like?
No, I don't have to get that. I take a baby aspirin every day. Still take the blood pressure medication.
Can you explain to our viewers real quick the Watchman if they're asking?
So the difference between an ablation and a Watchman is quite different, right? So the common myth is the Watchman treats AFib. It really does not. It basically is an alternative for patients who need to be on blood thinners, but who cannot take blood thinners because they have a complication from being on blood thinners, right? So in Daryle's case, his risk of a stroke is very small, so he really does not need to be on a blood thinner. But in some patients who have diabetes or heart failure or who are elderly, they need to be on lifelong blood thinners. So in those patients where they need to be on a blood thinner but cannot be on a blood thinner because of, I don't know, bleeding or frequent falls, we implant a Watchman device. So it is basically a filter that filters out the blood clots and decreases the risk of a stroke, but it really does not treat the atrial fibrillation as much.
And it's nothing that
Daryle
needs. Anna has a question that she submitted. She wants to know, will Daryle have to have this procedure again, or does this cure him of AFib for good?
So that's a very good question. So the chances of AFib coming back after a successful ablation is about 20% or so. So the chances of repeating procedures is about 20%. And the reason for that is, first, anytime you treat any portion of the heart, there's a chance that that portion of the heart can actually grow back. So if it grows back, you have to go back and zap it again. So I wish I could tell you that there is a procedure that you do it once and it cures an arrhythmia for your lifetime. Unfortunately, that does not exist. So he still needs a close follow-up.
Right.
And if it ever AFib comes back, we still have to go back and treat it.
And that's what the smartwatch
That
will
is
help
correct.
you
Right.
indicate, because
That's
you
right.
don't, you're sneaky. You don't feel the symptoms.
No, I don't feel it.
Susan, when was your AFib and the treatment for it?
June of 21.
So what procedure was the pulse field? It wasn't available then. So
No.
what kind of procedure did you have?
I had the cryoablation.
Okay, and so you've
freeze
been monitoring since with your watches.
Yeah, I haven't had anything. I was on some medications for about a year. I know.
Knock on for
I was knocking already.
This is right.
But I was on medications for about a year, and then it had no problems.
Right.
So
And that's great. What kind of medications do you prescribe for AFib?
So after the procedure, we typically leave patients on something called anti-arrhythmic agents, and we do that for about 3 months or so and then stop it. In Susan's case, we were a little bit hesitant stopping it, so I just continued it for some time and then we stopped it.
Jim has a question. Jim wants to know, would the old procedure ever be preferred to pulsed field ablation? Or do you prefer pulsed field ablation to every patient?
Man, it's that's a good question. So it's not that the older procedure did not work, right? It worked for decades. So whenever you see newer technology, the first thing you look at it is it the same as that of older procedure? It certainly is. But what distinguishes this technology is how safe it is. The fact that the risk of a collateral damage is essentially eliminated makes it a very, very attractive option. So a quick answer would be, I really cannot see myself going back to an older technology. Again, not that it doesn't work, it's just that we had better energy sources now and certainly much more safer than what they were in the past.
Well, when you describe a procedure as a quantum leap,
right.
It
is.
Making progress, you're not going to want to go back to the old way of doing things. This has been such a great conversation. As we wrap things up, I'd love to get every guest's final thoughts from all three of you. Susan, I want to start with you. You're on the hot seat. There's no hot seat. You're doing great. What's it like to be sitting here now next to your husband and the doctor you work with, and your husband's feeling great? What's the message to our viewers?
Don't wait. If you know something's wrong, get in and get it checked out, because it's not worth the risk. Just check it out.
And Daryle, can you describe to our viewers your experience with Dr. Yarlagadda and how?
It's been great. The procedure was easy. The recovery, it was easy.
And you're back to fishing. When are you going back to your special place next?
Very soon.
Yeah, right after the show, you're jumping in the car with your fishing poles, you're heading out of town. Dr. Yarlagadda, what would be your final message to our guests?
So, the thing about AFib, it's a silent arrhythmia, right? It really, in most of the patients, unfortunately, the first time we see them is after they have a stroke or something bad like that.
Right.
So, in the past, we used to treat atrial fibrillation with medications just because we were hesitant to do procedures which potentially can have some complications. With this form of energy source, where the risk of collateral damage is small, so we are more aggressive in offering this to patients. So, so if you do have any rhythm problem, I mean, we have really excellent ways of treating it with very minimal risk at this point.
I just had a thought about our high school sweethearts here. It's not related to AFib, but have you ever thought the eye patch is why you guys hooked up? Because it caught his eye?
Yeah, it was.
No pun intended, but he saw you walking down the hallway with the eye patch on and thought it was kind of cute and quirky. Thank the eye injury for you having your soulmate here.
There you go.
We love having our guests on the show, and we love being able to share the incredible work of our doctors here at the health system. Have you ever wondered what your doctor does outside of work?
Now for a secret look into the guardians of healthcare at the University of Kansas Health System. Let's go behind the mask.
I told you this would be fun. Dr. Yarlagadda, we're going behind the mask, and apparently in your off time, you're climbing mountains and running marathons. Most people take naps and catch up on Netflix. You climbed Mount Kilimanjaro. When did you do this, and how long did it take you to train?
So that was one of the best experiences actually of my life. So I did this in February of this year. February of this year. It's just a very cool experience.
Was this your first mountain to climb?
No, I actually hiked in Patagonia before, but this is the first major hike. So it took us about 8 days to climb that mountain, and those pictures are from the summit of Kilimanjaro. It's a great feeling to be on top of Africa and look down at the savannas. It's
so
cool. Just one of the best feels and best trips I ever did.
I bet it also felt good to run your first marathon.
Right.
Now, of course, he's a marathon runner. We have a picture of you having just completed the Chicago Marathon.
Yeah, that was last year.
Yeah.
That was last October.
When did you start running marathons?
The first marathon I ran was when I was in training. I trained in New York. So I ran the first marathon, and now I'm dating myself. It's in 2003.
Oh my gosh.
2003 was my first New York marathon, yeah.
And
I ran it again after that, yeah.
Do you run every day in Kansas City area?
No, I wish I did, but I tried to at least get a run. Yeah, I trained for it. So this year,
cool.
This year I really did not do any. Last year I did both Tokyo and Chicago. So
you took it easy.
Yeah, this year I did take it easy. Yeah.
Thank you so much for being here and joining our program. And Daryle and Susan, thank you for taking the time to share your journey with us. It's been such a cool conversation. And if you'd like to share or watch one of our previous episodes, just scan the QR code on your screen right now. It'll take you to links to all of our previous shows. Next Thursday's Thanksgiving, so we'll be off observing the holiday. We will see you, though, with a brand new episode of All Things Heart on December 5th, and this one's quite a story as well. What began as a day of bowling for this couple ended with 2 ambulance rides and ultimately 2 surgeons from 2 different specialties here at the health system working as a team to save Steve Overhellman's life. That's December 5th at 8 a.m.
Coming up tomorrow on the Morning Medical Update. Thanksgiving is a time for family and gratitude. But when table talk turns to politics, tempers can boil over faster than the gravy. I'm Jessica Lovell. On the next Morning Medical Update, practical advice from psychologists for keeping the peace and protecting your well-being this holiday season. Friday at 8.